another minute, and then I can just go through the slide and we can let her know what we think. But we'll see if she comes through again. All right, well, in the interest of time, since Dr. Hitt was so kind to provide us with these slides for a case she asked us about. So this is a 15-year-old who was diagnosed at age 14, and you can see there BMI not so high, 63rd percentile, very high A1C of almost 17, but without ketosis, ketosis without acidosis, and symptoms that were only lasting a few weeks with a significant weight loss. And antibody testing negative on metformin alone, had been on insulin, and you can see there currently A1C is 5.2, and we'll just go on to the next slide. And family history is notable for type 1 in a grandparent, type 2 in maternal grandparents, a cousin, maybe pre-diabetes in the father. There was an initial genetic testing panel, sort of the usual suspects were negative, and testing also for, I'm not sure why, maybe Cushing's or Addison's, but that's a little confusing, but there it is. And mild acanthosis, C-peptide reasonable, no other physiological evidence of lipid dystrophy. And the next slide.
I believe that was the last slide.
Oh, is there? Oh, right. So that was the last slide. So the question becomes, what do we do? So this is a little bit like the conversations we have in Radiant that Dr. Goland and I and Lisa are very familiar with. The question is this someone to continue to pursue monogenic testing? The interesting clues for something that isn't the usual things are sort of negative for antibodies, off insulin.
Lou, could I interrupt for 1 sec? So
yes, please.
You went by it pretty quickly. How many antibodies and so this is a young man so that's a lot of antibodies. Okay. Who's got 2 relatives with type 1 diabetes. So the way the Radiant algorithm works is that we will retest the antibodies. But a thin 15-year-old, right? Thin, yes?
Well, thin-ish. I mean, I would say not obese. So 53rd percentile. So I don't know, in the scale they use in Harlem, that's already pretty big, right?
When there was the significant weight loss, so they were originally, I think, 90th percentile for weight and now down to 65th.
Yeah, okay. So that's our significant numbers of antibodies. I thought maybe only 1 antibody that was negative. That would sway me a little more, because with 2 relatives that have type 1, that is pushing me, and the young age. But 4 negative antibodies I find impressive.
Right. So then the question becomes, given the other features here, is this antibody negative type 1 in a adolescent teenager with a family history of type 1, or do we think that there might be some other genetic relationship that we need to continue to pursue in a study like Radiant?
And I don't think she provided us with information on how long this person has been off of insulin, but sounds interesting that they're just on metformin now with an A1C of 5.2%.
So that's on the one hand. On the other hand, we see not infrequently people with fairly long honeymoons, which this could be. So it's possible that, again, as we wait longer, if it is antibody negative type 1, then with time there will be a reduction in C-peptide and the need for insulin going forward. The C-peptide, which is on the next slide, if we look at that again, so I apologize then, I went through a lot of information relatively quickly. So this is, as I say, this is a learning experience for all of us. So the C-peptide was middling and we don't know actually where that is. One of the things we're trying to understand is what is C-peptide in relationship to the glucose at that moment, and whether it was random or pre or postprandial. So a middling C-peptide is not particularly helpful without that information and without a trajectory. So I think, so the discussion is still that given, so negative antibody testing, negative monogenic panel, and is it too soon to tell, or do we pursue additional research testing?
Lou, could you go back to the last slide? Because that you also went, so did he really have an A1C of 16.8% at diagnosis?
Well, that's the information we have. I'm just, it's possible, is Dr. Hitt on, someone has called in. I don't know who that is. But that's not Dr. Hitt.
I believe that might be Dr. Hitt.
Okay.
Dr. Hitt, is that you on the phone?
Who's muted?
If so, you're muted. Okay. Well, she did say she was going to try calling in, so that might be her.
All right. Well, so, I think what we're seeing more and more is that this kind of picture, even though the initial BMI was high, that I would still be leaning to antibody negative type 1 in this situation. And it's an argument for being able to do, additional studies, such as the type 1 diabetes genic risk score, which again is not definitive, just like any of these would be. But Robin, so if this was a radiant case, I think we would lean to the negative antibody negative type 1.
I agree. And I think that in radiant, because the other problem that we face here is where these antibodies were measured, that when we measure them again, it's possible that this young man would have a positive antibody. That wouldn't shock us. Then he would have antibody positive type 1 diabetes. That would be clearer. If his antibodies are negative, this is a perfect radiant case because it's completely unclear to me what the diagnosis is here.
Right. So, which is terrific. And I mentioned also that when we do have cases like this recently, we mentioned the recommendation of the Hattersley group about C-peptide. And so they're doing urinary C-peptide, which is certainly not standard in this country yet. They're doing it postprandial, and they're looking for low C-peptide 3 to 5 years after diagnosis as also an indicator of absent insulin secretion, which would be more consistent with type 1. So here it's too soon to tell. So I think, that unless someone else has questions, I think that's what we're going to, that'll be the summary of the conversation we get back to Dr. Hitt about this case, that we think not a radiant case just yet, but
Hello.
I think she just joined.
Oh, there you are.
I think I'm here. I can hear a little. I'm sorry. I don't know what's going on and why this meeting passcode's not working on my computer. So I really apologize for that. Thank you so much for discussing my case.
Yeah, do you have anything to add or that would help us think about it a little bit more?
So I only heard a very little bit when I was joining last, and then I had to leave to try to rejoin. So I think what I heard is that you guys were thinking that it sounded like antibody negative type 1. Is that correct?
Yeah, so having put it all together, I think that's the summary, that high A1C, even though the BMI initially was high, negative antibodies, it could be a honeymoon period, negative initial monogenic testing, middling C-peptide that's not informative. So was there something else that you felt would be important here in the consideration?
Yeah, I guess my wonder is really this patient has I was thinking he really seemed to be following more like a type 2 pattern. There is acanthosis nigricans, although it's not that significant. And I am going to resend a C-peptide as well as an IA2, because I realized that of the antibodies I sent, that one was not specifically sent. And I thought maybe that would be of use now that it's been a little over a year. But, he would kind of be past, I think, the honeymoon period. I guess I just was treating him more like a pediatric type 2 diabetes given the acanthosis and the fact that he was overweight initially. But again, he really has remained at a good weight, a good BMI. He is very athletic. But it sounds like you guys are kind of thinking more he seems like a pediatric, like a potential negative antibody negative type 1 instead.
Yeah, I think, and so I can have maybe Dr. Golan would speak again to this, but we're seeing quite a few folks like this, and the honeymoon period, and Dr. Greeley has joined us too. The honeymoon period can last an astonishingly long time. So certainly in older people, it can go on for years. In adolescents, it's a little bit more unusual to go on for this length of time, but we certainly have seen it, and of course I think the acanthosis is probably not helpful actually in our experience at this point. So I would continue to follow. I mean, the question then becomes, what is the best treatment?
We think he's very unusual, right, Lou? I mean,
well, so the question is how unusual. I mean, we're the more we look for antibodies, and I just heard a presentation this morning. Dr. Greeley and I were at a presentation on one of the type 1 intervention trials, and they're also seeing a surprising percentage of antibody negative folks who otherwise look all the world for type 1. So it may be that this fellow is in the 5% group for children, but maybe, I don't know, Siri, did you see enough of the slides to make comment on that?
I was curious about ancestry, if anyone said anything about that. And
Sorry. Yep.
And is he doing well on just the metformin?
Yeah, so he is African American and he's doing great on just the metformin. I mean, his A1C has been at the last visit was 5.2, 5.3. Was the time before that. He came off of the insulin. So let me see, I'm just going back a little bit in time. So we did have a very high A1C on diagnosis, but the visit after that, his A1C was 11.8, which was, about 1 month later. And then the visit after that, he was 5.4. So I believe at that time, I was starting to wean his carbohydrate coverage. And I think I even came off his carbohydrate coverage at one point in between that visit and the subsequent visit where he was 5.3 when he came in. I did only slightly go down on his Lantus, kept him off carbohydrate coverage, but then, he stopped it on his own at home. By the time I saw him the next time, his A1C was 5.2. So he's remained with a very low A1C. So it would be pretty, a decently significant honeymoon period, which is definitely possible. But he is also very athletic and has acanthosis. Father told me at the most recent visit he had pre-diabetes, recent diagnosis. So I guess I was just kind of wondering if he could be a type 2 diabetes, given his initial weight was higher than the mild acanthosis. But yeah, there's definitely a possibility this is a very significant honeymoon period as well in the type 1. And then with the MODY, the real question I had was, further MODY testing I should do if the initial panel was negative. Is there should I have him join the registry, things like that?
I think I agree with you that this sounds more to me like the type 2 ketosis prone kind of situation, more so because with the type 1s, I feel like the honeymoon is usually not so pronounced that you essentially don't require any insulin. I mean, I don't know. I mean, of course, anything is possible, and Lou has probably seen all kinds of different things. But the only thing that argues against the type 2 kind of ketosis prone thing is the lack of obesity, but the fact that he had such significant weight loss at the beginning makes me wonder if metabolically speaking, he was more like type 2. And although you're saying he's athletic and everything now, I'm curious, did he, were there significant kind of lifestyle changes that have gone on over the past months or however long this has been? Like, is he eating a
For this
healthier
past
diet?
year,
that kind of thing?
I do think he is eating a slightly healthier diet. I think his activity may be similar as far as I can tell. He's, a basketball player, and he's been kind of playing sports throughout my time with him, and it seems like he was playing sports previously. But I do think maybe the diet is a little bit better since the diagnosis.
Right, so I think, we booked these cases very tightly today, and I see Dr. Kim is
Oh
waiting.
yes, I'm so
So,
sorry.
no, so we're gonna come back to this case, I think. So we have two possible diagnoses here. One is antibody negative type 1. The other is young onset, ketosis prone diabetes, which would be extremely interesting. Both of them have ramifications going forward that, we over the next year, even 6 months, we might see a trajectory and we could come back. As far as the specific question, I would not pursue any additional monogenic testing right now, but we could enroll him in our registry here in Chicago, because then we would at least collect blood to hold for our 200 gene panel, and we could do the type 1 genetic risk score, which may be useful in non-European populations. So let's.
Lou,
So
I would
Yeah,
note
that would
him
be
as
great.
eligible for Radiant. You don't think
Well,
so?
I'm leaning towards not, but series formulation, makes it seem like it could be. So I think it would be interesting then to see what a Radiant adjudication panel would do. And if he enrolled in Radiant, we would be able to repeat the antibodies for free.
Yes.
I think he would qualify under the ketosis prone guidelines that we have, that are more helpful for adjudication, like getting through.
So
And-
let's do that. So Dr. Hitt, so you can see how this conversation, it varies. So we have now several different possibilities, but the Radiant study, I think, would be, at least we would get additional information. So that would be helpful.
And
Okay,
one
that would
quick
be great.
note about the A1C at diagnosis of 16, that
Mhm.
MODIs tend not to be quite so high. So I
Right.
agree with Lou about not doing further testing, but great case.
Yeah, it's wonderful.
Okay, that sounds good.
We
Thank
really
you.
appreciate it. Thank you. Yeah.
Absolutely. To just get information about the Radiant and getting him involved, will someone be sending me an email, or can I reach out?
Yeah,
to you?
Tiana put the Radiant website in the chat, but
I
we'll
forgot
also.
she's over the phone, so I'll go ahead and email you that information.
Oh, right. Yeah, we will email that to you. We'll definitely follow up.
Thank you so much.
Awesome.
I really
Thank you
appreciate
so much.
I really appreciate it. Thank you so
Okay.
much.
Thank you. So, yeah, so I think, everyone, we have, so, the people who haven't done this before, I mean, these things take a while to develop. And unfortunately, we have people who have some interesting insights. So Dr. Kim, I'm sorry, we are a little delayed, but why don't you go ahead and we can see your case?
Sure. Thank you guys so much for letting me participate and join. So I have this case recently diagnosed with diabetes at 16 years of age, currently 17. And his initial BMI was 88th percentile, as you can see here. He presented with hyperglycemia, symptoms, polyuria, polydipsia, a little bit of weight loss. Mom checked blood sugar was really high, 500s, came to the ER. So when we did the initial labs, his A1C was actually 9.5% and blood sugar was 191 initially, and C-peptide was 4.7. Ketones were only 0.22 at a normal pH, so no acidosis, no DKA really. And we just started him on subcutaneous insulin and went from there. His antibodies have come back negative. He's currently on intensive insulin management with insulin to carb ratio, along with long-acting insulin. And currently his weight has gone up a little bit, and his A1C was 7.4 at the initial follow-up about 30 days after, and that was the one time that I've seen him so far. And then other medical history, really it was a family history that caught me too. for him, there's some history of maybe something with his eyes, maybe uveitis, maybe not quite sure. So that was just the one thing in his history, otherwise previously healthy. But family history, mom was saying dad has a history of type 1.5 diabetes, diagnosed in his 20s initially because he had high fasting blood sugar in the 130s to 140s, but then he didn't follow up. And then in his 30s, he was quote unquote sick with ketones in his urine, was not obese, BMI of 21.9. And he initially was started on metformin, and then he switched to insulin and has been on insulin for the past 9 years. Also Trulicity, they mentioned. And then dad's dad, they mentioned, told type 2 on insulin, also not obese. Don't know too much else about that one. And so did do some genetic testing, and the only things that came back were variant of unknown significance in these two genes, APPL1 and RFX6. So I guess I don't know if it's just antibody negative type 1 diabetes versus checking for MODY, but it came back negative other than these variant of unknown significance. So yes, I was just wondering your guys' thoughts.
Well, I can introduce the thing, and then we'll start to some. So in some ways, this is reminiscent of the previous case also, that it's an adolescent, that the BMI was a little bit on the high side. In this case, 88%. The previous case was, I think, 90th percentile or a little higher. A1C is high. And interestingly, the C-peptide is relatively high. And so that can be confusing, but, you know, people can comment on that. I don't think that's particularly helpful. Very modest ketones, and a few other features there. And then so there's interesting family history. So that's interesting. And so people should comment on that. And I can just comment, since Dr. Kim shared with us the genetics a little bit, we had a chance to look into it. The APPL1 there's like basically one paper, and it's from the Joslin, it's from our friends there. And it's a very interesting, complicated gene, and only the sort of the two families they described, and incomplete penetrance. So I don't think we really were too excited about that as being a possible cause, although we can't completely rule it out. RFX6 we can rule out as a heterozygote, and also the gene frequency is just way too high. So I don't think it's that at all. And let me see, total daily dose. So Lisa wants to know, how much insulin is this person on?
When I saw him, he was on 0.7 unit per kilo per day.
So close, but maybe a little bit high. So with that, other people weigh in. So the question is, really, is it antibody negative type 1? Is it maybe an early version of ketosis prone diabetes again? Or is this something we should be looking for with additional monogenic testing, or a radiant case?
One comment I'd like to emphasize is the more impressive family history here.
Yeah.
I think it makes it much more compelling as potentially pursuing things further. So when you have both the father and then the grandfather, and when you have the father having this, history of quote unquote 1.5 type 1.5 term that I don't like, but at least it shows that people have been confused even about the dad's diabetes. So that is interesting. But another comment I would make, almost regardless of what the diagnosis is, the fact that he has such a high C-peptide, I would be inclined to consider non-insulin therapies in his treatment, just because he's making a lot of insulin already. There's some great, with all of the type 2 drugs that are available now, and given that his BMI is a little on the high side, it sounds like maybe his dad is responding well to Trulicity, and so that might be something to think about. I know in peds endo, traditionally we haven't been very good about knowing all the different treatment options. We like our insulin, and we're very good at insulin, and we do a little metformin. But I think I've been trying to help our fellows to become more comfortable, because I think that really is where we're going towards the future. So that's just one kind of side comment. I'm honestly not quite sure where to go from here, though. In terms of the APPL1, one thing we could do is we could send it out to our MDEP group, which is an international expert panel that reviews variants in all kinds of monogenic genes. And so it's possible that other people have seen this variant in a variety of clinical healthcare systems or laboratories, and that could be helpful. But it might, in the meantime, because it's going to be pretty uncertain, I think, for the time being with that gene. I mean, I'll be curious to hear what Lou would say, but I think this could be a radiant family.
Well, right. So before I weigh in, Robin, did you want to, because you thought the family history was interesting.
Yeah, I think the family history is extremely interesting. I agree that I am not a big fan of type 1.5 diabetes. Sounds to me like this young man's father has type 1 diabetes. I'm also not a big fan of using type 2 drugs in the young adults that I take care of that have type 1 diabetes, because it doesn't change the natural history of the disease and it confuses them quite a bit. And when they actually need insulin, it's a real big fight. I think to manage the obesity is a whole other story. And I'm really not swayed very much by their C-peptide. A study Carla Greenbaum did in the exchange population, and we had contributed a bunch of those people with 50 years of type 1 diabetes. About 5 to 10% of them are still making significant amounts of C-peptide. So I think we have to be careful about the C-peptide, not as helpful as we might think. So I always think people are interesting, even though Lou thinks I don't. I think this is pretty interesting. And I think what is happening with the eye problems in this family, and I think it's completely unclear what form of diabetes this patient has. And I think and you guys are not clear what the significance of the genetic findings. So I think he's a perfect radiant referral.
Yeah, the advantage, I think, of radiant right away, and Lisa also put a note that that this would someone who would likely go on in radiant and not be excluded by any of the criteria. So we could also enroll the other 2 family members of interest. So we would be able to get the genetics on everybody without any additional charge. We will be able to see whether the APPL1, which I think is potentially the more interesting, although I think neither of them are that interesting, but there could be something else. And so the advantage of radiant is as you know, Dr. Kim, we're not doing a handful of genes, we're doing all of them and all the other regions. So I think, I didn't mean this hour to be a radiant advertisement, but it is a way to get the things that we need. So we can repeat the antibodies. We could then, if dad joins radiant, then we could repeat antibodies on him. So even at this late date, if it really is type 1, it's possible dad has never had antibodies, given that he was diagnosed in his 20s and it wasn't standard of care. I mean, it's still not standard of care, but this way we would get antibodies on everybody. And if even one of them was positive, that would maybe change our thinking. So I do like the idea of enrolling the young man, but seeing whether the dad and and maybe talking to his doctor that would help us. Do you know whether the dad and the paternal grandfather, are they all in your area?
I think so. I'll have to ask mom about this again.
Right.
I can't quite remember. I think dad at least.
Yeah, so I think it's a big advantage to get the whole family enrolled in Radiant, and for all of those reasons, the genetics, the phenotyping, to be able to, maybe there's other family members besides, maybe the father has siblings that are interesting. from this point of view anyway. So that would be a way to collect all that information.
The other thing I'd like to point out is that when I started many, many years before Lou, it seemed to me that it was very clear my patients either had type 1 diabetes or type 2 diabetes. And the older I get, the less clear it becomes. I'm not sure what the problem is really, but it's are very interesting case presentations.
Just for the record, Robin and I were in the same college class. Okay, so just, relax about
But he was 12.
A couple of quick comments is that since the sequencing was done in our clinical lab, technically we could enroll them in the monogenic study, and we could take a look at kind of the backside of that testing panel to see if anything else pops up. But I also don't want to take away from encouraging them to join Radiant.
Right,
So
right. I think
I wouldn't want to confuse things too much. And just to address, I do want to address Robin's point about the type 1, type 2. I don't want her to think I would treat anybody with any amount of C-peptide. It was because I thought in this case, it's not clear that the patient has type 1, the antibodies were negative. But in addition, the C-peptide was especially high, as Lou kind of mentioned at the beginning. I completely agree that at the beginning of type 1, many people will be C-peptide positive, and we shouldn't necessarily go with that. But it was more this particular situation.
Great. So I think we have, we don't have an answer, but we have a pathway forward. So, I think absent the research study, we'd be scratching our heads. But I think that gives us some additional insight. And Siri's right. What we could do both things at once. We can look at the rest of unmask the rest of the panel but we would need the family to sign the consent, or if they haven't already, for the research part of our clinical colleagues' genetic testing, and then go with this. So that's wonderful, and we will look forward to seeing this family enrolled in Radiant.
Thank you guys so much. So,
Right.
all very helpful thoughts.
We'll be sure that you get the information, and we'll facilitate anything we possibly can. Okay, so I see Dr. Kretschmann is on. We're actually not running too far behind, but Dr. Kretschmann, would you like to review the slides here?
Yes, thank you. Thank you for having me today. I'm excited, and I always appreciate all the collaboration that I have when these cases come up. But I had an interesting case come across to me. I'm an adult endocrinologist not too far away in Richmond, Indiana. So my patient is a 19-year-old female. And as an adult endocrinologist, she just established with me last year. She was diagnosed with type 1 diabetes at 14 when she went to her doctor with polyuria and polydipsia. She was found, I don't have any records of this at the time because it was at a different facility, but she maintains that she always had a normal BMI and height or weight. So I don't have any of her pediatric growth curves. But at the time, her blood sugar was over 300 with an A1C around 11%. She was transferred to a pediatric hospital in Indianapolis called Riley. I did talk with that pediatric endocrinologist who assumed her care later. It was a second, and he said that reviewing the record, she did not have DKA at diagnosis, and that her antibodies were negative. They had looked at the GAD65, the islet cell antibody, and the insulin antibody. We are repeating those antibodies now, but I don't have the results back. Her medications, as she saw me last at the end of October, she's on Admelog at an insulin to carb ratio of 1 to 10 before meals with a 1 unit correction for every 50 above 120 and Basaglar 18. She's been on multiple insulin therapies before this, but she's never been on any non-insulin therapies. Her current BMI was 21.29 with a height of 5'3" and a weight of 120 pounds with an A1C at her last visit at 5.8%. What was interesting to me at the time of this last visit is that she had come in with a typical complaint that her insurance wasn't covering the Basaglar, that she wasn't able to get it because of a prior authorization status. So she had come into that visit with not being on basal insulin for about 2 weeks period of time. And her blood sugar was around the 100s. Now, granted, she had taken the Admelog, but she was also on a Dexcom. and had an average sugar of about 170, and her A1C was coming in at 5.8. So that's kind of what really sparked my interest, is to say this doesn't seem like somebody who is classically diagnosed as type 1 diabetes, because she has been without basal insulin for a 2-week period of time and pretty reasonable glucose control. She has no other medical history. She did have a recent CT of the abdomen due to abdominal pain a few weeks prior to this, but this was while she was on insulin. And her labs were very stable from the ER, so her sugar was even in the 100s. It did mention a non-visualization of the gallbladder, maybe surgically absent or contracted, but she's had no surgical history. In her family history, she does have a father who has diabetes. I misunderstood. I think, Lou, I emailed you that he had type 1, but after talking with her, she said that it was actually a pancreatic injury. So he had some sort of procedure, not quite sure when the procedure occurred because he was a truck driver on the road. They think it was an ERCP, and this resulted in an injury in the pancreas, and he's been on insulin since, but he was younger, maybe in his 20s or 30s when this happened. She does have a maternal grandmother with type 2 diabetes who was also older when they were diagnosed, and a paternal grandfather with type 2 diabetes. There's no other autoimmune disease in the family, no other history. So we did the in vitro testing, and her genetic testing came back as the PDX1 gene, as a heterozygous status, as a C188. And immediately when I got this, I just emailed Lou because I didn't know what to do with this result to kind of review the case. I think I have a little bit on the next slide, which really just kind of goes through that, the statement. I apologize. Her average glucose was 163 without being on basal insulin. And really she was steady overnight. It barely even had any dawn phenomenon, with a 73% time in range. Her A1C has always been below 7. And I don't think I put the recent C-peptide testing that we did with these labs. Her C-peptide was 0.3 with a glucose of 108.
Right. Well, this is terrific, and thank you so much for sharing this all with us at several different times. So, you know, in a nutshell, a young person with several year history of diabetes, with again antibody negative, and a really interesting family history and some other features that turn out to be relevant, like no gallbladder and a father with a funny looking pancreas. So the bottom line here is, when I wrote back to Dr. Kretschmann right away saying, oh, PDX1 is like never a cause of monogenic diabetes, except this mutation. So this is a mutation that Graham Bell and Steve Fyans reported first over a decade ago in several large kindreds throughout the Midwest. So this is it's a stop. So it's very interesting that it's a stop codon, not an insertion or some other change in the sequence, but these people are basically heterozygous for an absence of one of the PDX1 alleles. And typically people with homozygous PDX1 mutations, and Siri, I think, probably has seen more of those than anyone, or except for Andrew Hattersley, you know, those people have an absent congenital absence of the pancreas, and essentially neonatal diabetes, of course. So I'll let other people speak more about it, but this is very interesting. And of course, it raises the question of whether the dad actually had an injury, or they just actually discovered what he already had, which was that he was missing part of the pancreas. So in looking at this mutation again recently, because of this case, I came across a report from Brazil that people with this exact variant have a missing a part of the pancreas typically. And because PDX1 is involved in other GI development, you can have either small misshapen or absent sections of the pancreas or other GI features. So the question is what to do, and how to actually define the rest of the family. So I don't, so either Siri or Robin, if you want to pick up on this, but I think it's fantastically interesting, and it makes it very important to get the genetics on everyone in the family who might have diabetes.
Just a maybe slight correction out there on your mention about the Brazilian case with the possibly abnormal pancreas, and you said it's typical. I don't think there's anything typical
Oh, they had one
about these
family.
cases, in the sense that we don't know enough, and we haven't done enough phenotyping of enough of these cases to know for sure how often would they, for example, have a smaller pancreas. The studies that have been done, which includes, as Lou mentioned, the probably the biggest family with Steve Fiennes and Graham Bell, even in that original family where they kind of, it became Modi 4, there was a slightly incomplete penetrance, and it depends, like at that time, how old all of the carriers were, and possibly they were still yet to develop diabetes a little bit later. Some of them were on the overweight or obese side who had diabetes. So I think this is one of the genes that Hattersley and some of the other monogenic experts kind of termed the monogenic or Modi genes that have a little bit less strong penetrance than some of the others, but are probably very much a part of why this person has diabetes. I would be less inclined in this case to go searching for more other things, or for necessarily referring to Radiant, but I still think it's really worth collecting more information, particularly on the rest of the family. Like Lou said, we could, Invitae, I think, like most of the labs, if you request family testing soon enough after the original testing was done, they will usually do it for free. So I'd
Okay.
strongly encourage you to do that. But if you have trouble, we can actually do family testing pretty easily, and we would be very, very interested in having this kind of family in particular join the registry. So when they have what we think is a known cause of monogenic diabetes, that's like, we absolutely love to have any of all of those cases join the registry, so we can gather that information over time. And then lastly, and I want to let other people speak, but we don't really know the best treatment for these cases. For PDX1 Modi, it's such a kind of poorly defined clinical entity with these heterozygous variants, and there have been a variety of reports of different possibilities for treatment. And so even though a C-peptide of 0.3 isn't very much, it is something, especially that it's been, I think, 5 or 6 years since the diabetes diagnosis. The antibodies are negative. I think we have good reason to think this isn't type 1 diabetes. And that history you mentioned about being off of all treatment for some amount of time and not having DKA, we have found that to be a very, very compelling and helpful history in helping to kind of really steer us away from type 1. And so in that context, I do think actually you could consider some of the other treatments. I'm a big fan, for example, even as a pediatric endocrinologist, of SGLT inhibitors. I think would be something to potentially think about. So I'll just throw that out there for discussion.
To be clear, she was still doing the analog because she had it. She just didn't have the Basaglar. So she was just doing like half of what she typically would.
Yeah. Robin,
But she's
did
a
you wanna-
college kid too. So I asked her like how often she misses it, because I figured
Most
if
of the
I,
time.
like could have great glucose control without having to take my insulin, I probably would let it slide. But she seemed to indicate that she was pretty regular about taking her analog.
Okay, so maybe a little bit, not totally sure, but worth at least thinking about probably.
Mhm.
Robin, did you want to comment?
Yeah, I have two questions. One is very basic. So we don't have any patients with this variant in the practice that I'm aware of. I don't understand why they get diabetes. So are the basic mechanisms understood? I mean, if a small pancreas alone, there's still a lot of beta cells around.
Right.
So
So I mean, I think from that point of view, yeah. So I think PDX1, is as a transcription factor, appears early in development, and then the idea, if my memory serves, since I don't do this research myself, it is critical for continued maintenance of the differentiated beta cell phenotype. So why, this particular truncation seems to be more impressive than other modifications, I'm not sure. It maybe there's something very interesting about this. So it's early on in the protein at position 63, and then there's a missense and a stop. So I don't know that we know molecularly why this guy is
Yeah.
worse than others, but I can say that that it probably is multiple effects, that you have a developmental effect and a differentiated effect. I was going to say also that one of the interesting things here is to possibly look at contributions to the acid or pancreas, that this is one of those examples where fat absorption, fat soluble vitamins, fecal fat, fecal elastase, may also be part of the workup, which, we're just starting to understand. I think there's a growing literature. But Robin, you had a second question.
Yeah, and is the clinical problem here postprandial hyperglycemia? Is that what happens?
Yes, I don't know that anybody knows, and maybe this is the beauty of bringing this to our attention. We could recirculate the paper from Steve Fyans and Graham, and I would have to thank you. So Dr. Kim is gone. So we could, to everyone who's on this, we can send that paper around. And I believe there was a second paper, Siri, wasn't there? There was more. I thought there was a second, or maybe it was just an abstract that they followed up an additional family. But we can certainly revisit that paper, see where they go. A series, part of a study with Al Powers on using pancreatic imaging. Do you want to talk about that for a second?
Yeah, so this family definitely got us thinking a little more about which types of diabetes and which patients we might want to include in our study of using MRI modality as a way to measure and characterize the pancreas, especially in terms of size or volume. And we've been doing several other monogenic subtypes, but this would be a great additional family for us to, we would love to be able to do that with them. And so, especially given their proximity, I think that's very realistic, and we would, and especially if we can figure out with the dad and whatnot. But for the MODI, or I'm sorry, the MRI pancreas, it actually started from the antibody positive type 1s having a smaller pancreas leading into their development of type 1 diabetes. And we are still enrolling those antibody positive stage 2 type 1 cases, but we're now branching out into some of the monogenic subtypes. So this will be great to help with this family. I do just, I'm sorry, just one more thing about this case and the next one is that is a theme with these transcription factors that are also MODI genes, where when you have homozygous or compound heterozygous cases where there's a more extreme effect, it seems that the ones with heterozygous variants, that the missense mutations in the heterozygous state probably don't really do much of anything. But when we have these more severe truncating variants, like this particular one for PDX1, we think those are probably clinically relevant, although they tend to have this kind of variable incomplete penetrance kind of phenotype.
Right. So to summarize, and the other example of that is RFX6. So the Hattersley group is pretty adamant that the only interesting heterozygous mutations in RFX6 are truncations, not any sort of point mutation. So Dr. Kretschmann, the bottom line here is that you've come up with a extremely interesting rare transcription factor mutation in a very interesting family. We would love to, first of all, get all the family members genetically tested. We could do that in our study, or as we said, in some of the companies for not much money. We would want to image them. We would want to possibly do what Dr. Golan suggested, that we could devise basically a one-off study for this family to do things like glucose tolerance tests and a few other things, ship them here to Chicago and do that. And there would be, funds to pay for transportation and so on. So we'll continue to talk offline, but I can't thank you enough. And
Okay.
I think there's more to be found here that I think will be very interesting to follow up. And Graham Bell we haven't actually told him about the case yet, but he would be so happy to hear that there's another one. He thinks, for just as an end of this, he thinks that all of these folks are related, that the cases that Steve Fyans found in where in Ohio, where was the first family?
Yeah, I think they were from Ohio going east, and there was the baby in Virginia, and Yeah.
So he suspects this is all by by descent, and that somehow they're cousins or something. So that's
Or
probably
even
not
probably even more distantly related, but
right.
not like
Anyway,
not
so a rich discussion, and we will continue to follow up now.
Right.
So Robin and Rochelle, do you want to continue, or do you want to put this off until the next time? Are we able to stay? I can stay a few more minutes if most other people can.
I can.
Yeah.
Okay, so then let's go ahead. So since you're here and ready, let's do it.
Great, thank you. My name is Rochelle Gandika, peds endocrine over here at the Berry Center, working with Robin. And so appreciate the opportunity to present this case and get all of your opinion. So this patient of mine is now 15 years old. She first presented with new onset diabetes 3 years ago, at which time her BMI was not quite pediatric overweight, which would have been 85th percentile or above. She had 1 month of polyuria, polydipsia, some subjective weight loss, and found to have a yeast infection. Her blood sugar was 253 with an A1C of 13.2%, and she was not in DKA. All 4 antibodies at diagnosis were negative. And initially she was treated on multiple daily injections. She was at most on Basaglar of 10 units, carb ratio 1 to 10. Her corrections were really light at 100. And currently, as of a month ago, her A1C is now 5.7%. And she's actually on metformin now. I can explain sort of the evolution of all of that. But the next few slides are actually her anthropometrics. I thought it would be interesting to just show how, so this is her height curve where she's been along the 50th percentile and sort of settled out somewhere between the 25th and 50th. Next slide. And her weight. So you can see the 80th percentile or so after the diagnosis at 12, and then oh no, sorry, that was BMI, but she was above 75th percentile for weight, then floated up to the 90th, and now is back down to 75th. Next slide. And the BMI really did get up into the overweight, not obese category, and then came down. Much of this is the mother is extremely strict with what she eats, and after the diagnosis of diabetes really became much more controlling about having her avoid carbohydrates and sweets and things like that, and she sneaks it from time to time, but a lot of the jumpiness of the weight is related to that. Okay, next slide. So she was initially on multiple daily injections for 6 months, and first started to wean her prandial insulin and then her basal insulin. And the mother herself was on metformin, and she had a little bit of acanthosis. And so we decided to try it. And the dose that she's currently on is 1,000 milligrams in the morning and 500 milligrams in the evening. As I said, she's on a very strict diet at home, occasionally sneaks food, but also very picky. That should say no sugar sweetened beverages. Vegetables. Sorry for that. And she does still use the Dexcom. The mother uses it to just really make sure that she can continue to make sure that she will pick up on any early changes to high blood sugars. Okay, next slide. This is her medical history. She does have some mild intermittent asthma, only on albuterol when she needs it. Eczema. She does have an expressive language delay and learning disability for which she does qualify for extra services in school. She has myopia. I did find her last ophthalmology exam from last year, and there was no documented retinal problems. She did screen positive for depression in the past, and we're in the process of getting her therapy for that. She has acne, and she had menarche at age 12, and her menses are now regular. Her physical exam was really significant for a flat affect, and at the last time that I saw her, no acanthosis. She was 10 or 5, and really no other obvious dysmorphic features. So the lab history, the antibodies have been negative twice, both in 2020 and in 2021. Her C-peptide at diagnosis with a blood sugar of 319 was 1.4. Insulin level was 7, and her beta hydroxybutyrate was negative. Her TSH was 4, Hashimoto antibodies were negative, celiac screen was normal, and her lipids are listed there. Total cholesterol 158, triglycerides 109, HDL 41, LDL 96. The C-peptide was later repeated with the normal blood sugar was 1.11. And I had thrown in a high sensitivity CRP because this is before I did any kind of genetic screening. There was that paper from the UK group that looked at high sensitivity CRP as a possibly being suggestive for HNF1 alpha if it's on the low side, lower than what you would find with the type 1s and type 2s. And it was normal. Her another C-peptide was repeated, it was 1.4 with a blood sugar of 92. This is a year later, and her A1C is now down to 6. And as I told you, her last A1C is 5.7 with a normal microalbumin. Next slide. So the family history is very interesting. The mother was diagnosed with gestational diabetes during her first pregnancy at age 27. She was diet controlled initially, and then required insulin for this pregnancy and for her second pregnancy. And after her pregnancy, she was treated with metformin 500 twice a day. And then since then, empagliflozin and once weekly injection of dulaglutide have been added. Her A1C is 7.3%, which was done 2 months ago, but historically had been higher. Her brother was diagnosed with diabetes after the age of 40 and died from complications. I will mention the family is of Dominican descent, and the mother's a physician, and all of the family is still back in the Dominican Republic, except for the patient and her mother. There's another maternal uncle with diabetes who was diagnosed after age 40, takes pills and is in good control. And then there was also diabetes and hypertension in grandparents. The maternal grandfather had vision problems. His diabetes is now in good control, and the maternal grandmother is no longer living and had diabetes. The program has a 23-year-old sister who manages, who is overweight and follows a strict diet as well. And blood sugars have been a little on the higher side at 140s, as the mother had checked them. And with the diet managed, they're in better control. Saw a doctor 2 years ago and was told that she's pre-diabetic and is really working on lifestyle changes. And then there's another sibling who has what appear to be normal blood sugars. So upstairs in Dr. Wendy Chung's lab, they have the primers to check for HNF1 alpha and for glucokinase, and that was done back in 2021, and both were negative. And I did do in vitro testing on this patient earlier this year and was found to have a VUS in neuro D1. So talking with Wendy, she said it would be really important to screen the affected mother, and initially Invitae denied it, but I did appeal and they approved just to check for this particular mutation, and she does indeed have the same mutation as the daughter. So I think that's my last slide, and just interested in if what you think about this and whether she'd be a radiant candidate.
Well, so, to summarize, so an interesting family with non-autoimmune mild diabetes, I would say, relatively speaking, but doing well, but and some intellectual impairment, right? So
yes.
So looking back at sort of every paper that's ever been just written on neuro D1, which is less than 10, and some of them are pretty stodgy. This fits with whatever that is. The problem is we know so little about it, and it does seem to me that almost every case, every family could be a case report. I mean, that's where I think we are right now. Anything we could do, I think, to further characterize either the insulin secretion or the other clearly syndromic features, I think would be helpful. Clearly, I mean, the rest of the family is maybe unobtainable, but we could at least outline from the mother possibly who has what and whether they also have neurological defects, and whether there's some other things that we could do to further outline this thing. Now, some of the mutations are pretty, just like we talked about, and Siri mentioned with other transcription factors, that there should be very, so stop codons, huge frame shifts, other sorts of alterations, right? So this a lysine to asparagine, may not be that significant a change, and oftentimes, we do look at SIFT, polyphen, all the things that they mention in the bottom, and they don't put the score. So what we would want to do, so I didn't have a chance to do that before today, I don't know if we knew this yet, was we would run it through all of those things ourselves, and there's also then a summary to look at the score for each one and get a sense of how disruptive it is.
It actually says is likely to be disruptive.
Right. So that's not helpful. So,
Right.
What we would want to know is, so each one gives you a numerical score. So then there's a composite based on all these different analyses of what the difference is between a lysine with a terminal, quaternary amino group, and asparagine, which is not so not so crazy. It's not like it's a proline, or something totally different that would bend the thing in a strange direction. Neither is it a stop codon. And Lisa reminded me as we're talking that the Exeter group only reports nonsense variants, not missense variants. So the same argument is in RFX6. So I would have to say that, and then how other people comment, that this is still uncertain. I mean, it's interesting. It's
So that's what I was going to ask. So this is a family with a heavy burden of a type 2 diabetes syndrome. And how certain are we that this is why?
Yeah, I would say we're not. And so what's happened in the literature is that people, sort of the studies are published without connecting the dots. So there's not necessarily a clear mechanism from one to the other. Now, but on the other hand, it's not impossible. And what we would do is collect as much information as possible, see whether we could get, even if they're if they're contactable at all, and see what other family members do. And I think to characterize them as best we can would be good. I think one of the issues here is whether neuro D1 is a kind of transcription factor that would cause like visible defects. So, but maybe Siri, or someone else, you want to comment on where we go from here, because this is one of those very interesting cases that we're not sure what the meaning is.
Well, I think first of all, as I think you're implying, the fact that they carry a variant in a known monogenic gene, they qualify to join our registry, and we would love to get more information. And I think we could definitely do the family testing for them, since you had to get Invitae to bend over backwards just to do the mom.
Except that all the family is in the Dominican Republic, right? So
Yeah.
maybe not accessible. That's the problem.
It's not that far away, right? No, no, I mean to say, if people are visiting, we can do saliva kits.
Yeah, it wouldn't be the first time that Graham sent Siri far away.
Well,
to
yeah,
collect samples.
especially if you want to pay for my vacation in Dominican, that sounds awesome.
Right.
Lou, one of our fellows right now, one of our first year fellows, is from the Dominican as well. So she's on our IRB, she could theoretically do a house call. But anyway, I think we can subvert those barriers and enroll people. I think it's particularly compelling with the sister who is 2 points away from diabetes, whatever that means, and the brother who had some random blood sugars if they were fasting, might indicate some
Yeah, I don't know if
dysglycemia.
they were fasting.
But either way, since the mom is a physician, maybe she would be more interested in getting more information. It's a little challenging, and actually our team might be getting nervous with me even offering all this, because part of our challenge, even from a genetic testing perspective, is what are we going to say on the testing report for these ones who carry this variant. Is we kind of are going into it knowing we're going to be reporting something that's essentially technically a VUS. But we think it would still be helpful for us from a research perspective to get as many of these kind of families with these kind of variants over time to see how often it is that they are really developing diabetes. But as Lou mentioned, the Exeter group has kind of come down on saying that they don't report missense mutations in these genes. That's not the same as saying they don't think they do anything. It's just that it's really, really hard to prove it for sure that this is the cause of the diabetes.
Mhm.
And so they don't want to say that. But I think it's very possible that this is playing a role. But is it that the family also has, background genetics that predispose to type
Right.
2?
Right.
And this is like one thing, in addition to that makes them maybe a little more likely to have diabetes. That fact that mom is strictly limiting carbs, that although I feel a little bad for the patient, it probably doesn't hurt, her future ability to stay under better control. As we know, with any kind of diabetes, that kind of approach is probably going to be beneficial.
Right.
I think one question that Robin might be wondering, or we might all be wondering, is should we refer this family to Radiant, in addition to like kind of thinking about this monogenic variant? And I think that's an open question. We have at least one other case in Radiant who has a variant in a known gene, but in a gene where there have been so few cases reported that we don't really understand much at all about the pathogenesis. And so the adjudication committee, and I think it even went to the steering committee, decided it would be worth including them. So they might possibly say the same about this family.
Who should I reach out to?
So
I don't know, Lou.
that's
Any?
not come up on our committee. What do you think Rochelle should do?
I mean, one simple strategy would be just, you could refer them to Radiant, but just like warn the family that they might say no on the basis of this variant. And then, let the adjudication committee argue over it. And then if necessary, taking it to the bigger committee. I don't know if Lisa wants to share her thoughts or
Sure.
Lou.
Yeah, typically in the past, in situations like this where we have a variant that's a VUS, especially in a gene like NeuroD1, the guidance we give the adjudication committee is the case atypical or interesting outside of that variant? And if it is, then they should move on in Radiant. So this variant wouldn't hold them up if the committee felt the rest of the case was compelling.
Yeah, it's hard. I mean, I think I would try to find the very first paper for NeuroD1, which might be the one in the chat, but I'm not even sure that was the first paper. And the one that I put in there from, it was several cases in Iceland. Those are point mutations, not large deletions, and so they're interesting, but there's not much characterization of the family. I think you've done a great start here by characterizing them. I think what we want to do is get a sense of whether there's anything else here. So I think what we have to do is table the conversation for the moment and think hard about what to do. It is, as I said, it's possible this could go through Radiant because there is a variant, but the variant is of uncertain significance, as the reports say. So it may or may not be the cause, and Radiant, can't say exclude them. In fact, they would say you've done all the known monogenic genes that could be relevant. It isn't them, so it should be a Radiant case. And then going through Radiant, eventually we would do at least some phenotyping, which could help to define, this NeuroD1. I think what we said for Radiant since we wrote some of the protocol, was that very unusual things could be considered in radiant if they were poorly defined.
Mhm.
And that, so this could do that, and it would give you a mechanism to do the things we want to do, even a glucose tolerance test, repeat things, genetic risk scores, all the background which you might like to do, but otherwise there might not be funding or a mechanism to do.
Yeah, I think as Lisa said, it comes down to the fact that this is a VUS. And so technically that shouldn't stop them from
Right.
being included in Radiant.
Yeah.
And but then I think the question about the rest of the family is worth thinking about. For example, the mom, is she overweight, obese, and what
No.
about her brothers? Who
She's lean. I don't know about the brothers.
I mean, and you can, and it's hard to get all that information precisely, but if it seems like they aren't like screaming, type 2 diabetes, I think there's at least a decent chance they could get through the adjudication committee.
Yeah. So bottom line, incredibly interesting, a chance to really improve the literature, by doing more studies. It's possible pancreatic imaging would be the thing. Getting detailed neuropsych testing, could be part of a radiant idea, because we do that. So just figuring out the levels of detail, and neither mom or the daughter have had an MRI, for example, of the brain.
Not that I'm aware of.
So, what sorts of issues there, could there be structural issues that are, just no one's ever looked. I think it's a very amazing situation, and it just shows that when Robin told us about the Dominican population in the Bronx, I think there's maybe more to find. So this is great. So we took 15 minutes, but I think this was really important. We have a lot to follow up on. I can't thank everyone enough for doing this, and we're going to do it. I think we're going to skip December. Is that right, Lisa? And then do this again in January.
Yes, that's correct.
And but in the meanwhile, let's see about recruiting these folks, getting them into the other studies that seem pertinent, and find out as much as we can and improve the world's literature.
This was great. I learned a lot. So thank you for including me.
And thank you guys for bringing such awesome cases. We really love doing this.
I always learn from you guys, and look, I think what's exciting too is that people say, well, I found this one, I can find another one. So keep your eyes open.
Thank
All right.
you.
Have a great rest of the week, and we'll be sure to follow up.
And say hi to Wendy. All right.
Oh,
See ya.
we will. Bye.
And Rudy
Thank
too.
you.
See ya.
Absolutely.
Bye.
Bye-bye. Thank you.